be good to go.
Okay, well, first of all, thank you for having me here. And I chose a little bit of an off topic, and it is based on my observation over many years, especially in our system, that there's a significant increase in the use of non-invasive ventilation, and yet our comfort with non-invasive ventilation remains marginal at best. Next slide, please. So you'd be surprised that it's just not my observation. This is kind of the statistics and data from not only the United States, but all over the world, that the use of non-invasive ventilation has significantly escalated over the last 2 decades. And we obviously have to catch up with the technology, since it's patient care and can have impact on the outcomes. If any one of you rounds in the hospital, goes down the floor, and we did this a few weeks ago, you would notice all the patients who are on non-invasive ventilation seem to be on some magic number of 10/5. That seems to be like the universally accepted number where magic would happen and the patient will get better on its own. And of course, if it fails, then there's no other option but to take him to the ICU and intubate him. So it seems to be like the favorite to-do mode from non-invasive potential point of view. So this is in the story in the hospital. If you flip it towards the outpatient, more and more patients at home are also on some kind of device, non-invasive device, a home ventilator. And you often see them in your clinic and you wonder, hey, what do we have? And sometimes just leave it at, oh, you're using a mask at home and somebody must be taking care of it. Most likely a DME company got it. I need to not worry about it. So I think these are 2 fundamental questions which I'll be addressing as to what's wrong with these 2 questions and our approach, and maybe how we could potentially do it better. Next slide, please. So as was suggested, I would want to make this more interactive and make sure it is case-based so we understand the nuances behind these non-invasive ventilations. So let's first address the hospital aspect of it. So we have this 58-year-old male with history of CHF, COPD, some obesity, admitted for respiratory failure, possibly decompensated congestive heart failure. A very typical West Virginia patient. They don't come simple, so there are multiple issues going at the same time. Patient was rightly initiated on IV Lasix. He was on Duanab, started on a BiPAP. As I said, the magic number seemed to be 10/5 here too. And then he was bled some oxygen of 3 liters to keep SATs above 90%. His admission ABGs revealed a respiratory acidosis with pH of 7.25. His carbon dioxide was 65. Normal is around 40 to 45. PO2 was 67 on the lower end, and BICA was 28. So it's clear that this patient is in acute hypercapnic respiratory failure. And after the above intervention, a repeat gas showed his pH was 7.21, PCO2 was 72, PO2 of 66 millimeter mercury. And the resident was crestfallen because this magic number somehow did not work. And this patient is more lethargic, more acidotic, and has more hypercapnia. Next slide, please. So what can happen? What are the implications of default plug and play when you're using just one number with this BiPAP? Well, you just saw what happened. There's worsening of respiratory failure. You could go into altered mental status called the CO2 narcosis. This patient was lethargic, but a lot of patients may even go further and become comatose. Eventually, we require intubation and mechanical ventilation. And that basically means escalation of care escalation of cost, and escalation of complications, because none of them come cheap. Next slide, please. So what could have been done as a next step, considering there's a huge opportunity cost involved if you don't change the way you approach non-invasive ventilation? So should a patient be increase the BiPAP to 12/8 and try that? Now that he's lethargic, should it be intubation and mechanical ventilation? Or do you think that this patient had nothing to do with the ventilatory failure? He may probably be having more fluid in his lungs from the heart failure, and he should have been more aggressively diuresed. Or number D, short trial of AVAPs followed by intubation if no improvement in 30 minutes. Any thoughts, suggestions? What would people do in this situation? I don't know if there's a way to raise hands and say if you favor A, B, C, or D.
This is Dan Doyle, and
I
raised my hand, but and I know what I would say, even though there's something here I never heard of until today. But there's a respiratory therapist on this call who's doing regular work in a rural hospital in the ICU on the floor, and I hope he'll pipe up here.
Sure. Is that Harry?
Well, there might be more than one person. The one I know, and Kat Warner is an ICU nurse. She's probably dealt with this before. She's doing pulmonary. There's Tim. Go ahead, Tim.
Yeah.
You're muted, Tim.
Yeah.
Tim is Harry.
Okay, got it. Yeah, he's muted. I think Tim, you may have to unmute yourself.
He'll get it. Okay. We've overcome worse technical problems than
that. Okay, now can you hear me now?
Yeah. Please go ahead.
Well, I say try AVAPs.
Very good.
Pull that out of my back pocket.
I would not expect an RT to not have the right answer. So I'm very, very pleased. So I think that is the right answer for that. And then a lot of people may wonder, hey, we have heard of CPAP, we have heard of BiPAP. Now, why are you introducing AVAPs, and why do we do this? So we're going to go into a little bit more details about that. Next slide, please. All right. So many times, in order for us to decide on non-invasive ventilation, it is essential to have some data or physiological derangements which you're dealing with. You're at a much better position to deal with non-invasive ventilation if you're familiar with the physiological derangements that you're dealing with, not just the acute problem. So now, as we had stated in his history and physical, he's a big guy. BMI is 42. He's 6 feet tall, and he has some PFTs and overnight pulse ox, which we can review. And his PFTs clearly mention that he's got an obstructive ventilatory defect, suggestive of some moderate COPD. But look at his pulse ox. He's got severe oxygen desaturations. And then his ODI, which is basically a surrogate marker for AHI, is 38 events, suggestive of severe sleep apnea and possibly obesity hyperventilation syndrome. So now you know that there's derangement at multiple levels. You have sleep apnea, you may have OHS, you have COPD, you have underlying heart failure. And once you know that, then it starts forming in your mind as to what are the settings that may be beneficial to this patient without triggering intubation and mechanical ventilation. Next slide, please. Kelly, yeah. So since he has multiple physiological derangements, I put this cartoon of a regular BiPAP, which is placed at 10/15, and you can see the 5 is the EPAP, and the 15 is set as the IPAP, and the driving pressure is basically 15 minus 5, which is about 10. Okay. Now, when you have heart failure, when you have pulmonary edema all over your lungs, you don't need driving pressure. You don't need IPAP. You need EPAP. EPAP of 5 is very, very minimal, will not do anything to resolve this patient's pulmonary edema. So even before putting the non-invasive ventilation, we know that 5 ain't going to work. We need to go up on that. On top of that, we also have evidence that he has COPD. What does COPD do? It does air trapping. Air trapping causes auto CPAP or auto PEEP inside. And auto PEEP is actually treated with more PEEP or external PEEP. So that itself also negates the use of 5 centimeter water of EPAP. On top of that, he has very severe sleep apnea, 40 out of 42, and 5 of EPAP. Think of about CPAP of 5 centimeter is very minimal, if at all, to open up your upper airways. So that itself gives you an idea that your EPAP of 5 is not going to work out. And if you increase your EPAP, then even to improve your driving pressure, you'll have to go up on the IPAP. Okay. On top of that, we found out that his BMI is 42, his hypercapnia is way out of proportion, so he possibly may have obesity hyperventilation syndrome, so sometimes advanced COPD may also cause severe hypercapnia. Next slide, please. So the first thing what I'd go and do a bedside is, instead of putting the numbers in, I look at the settings and I say, what kind of tidal volume is this patient generating? And that is easily visible on your machine, whatever pressure you may put it on. So let's say this patient we have already talked about was placed on a 10/5 centimeter water, and that was generating 240 cc's of tidal volume. Now we know that a patient who is 6 feet tall and is a male, there is a certain formula which tells us how much tidal volume he actually needs. Okay. And that is formula which is, I've mentioned over here, is 50 plus 2.3. And then he's 6 feet tall, so you multiply 72 minus 60. And that comes out to be 77 kilograms roughly as his predicted body weight. And you multiply that with 6 ml per kg body weight, which is the regular tidal volume that we use for people. And that turns out to be 466 ml. So almost double the tidal volume which he was receiving. So he's receiving very inadequate tidal volume even for his respiratory failure. So that's a very quick thing I can do right at the bedside without even having much more information. The second thing I want to look at is the respiratory rate. Why is the respiratory rate? If you look at this cartoon over here, you see a whole bunch of airways all the way until you get to the alveoli. Guess what? None of this trachea and the airways are participating in oxygen exchange or air exchange, which basically means that these are nothing but dead spaces. Dead space do not work. Dead space do not exchange oxygen. And in any given time, even for people in this room, virtually not having any medical problems, 30% of our tidal volume is wasted in dead space, 30%. So if you take 30% of 240 cc's, which is around 70 cc's, this patient is actually effectively getting no more than 170 cc's of tidal volume. And that's why he's circling down the drain till he gets intubated. The other important physiological fact that we need to remember is that as the respiratory rate goes up, the dead space goes up. In fact, if you're breathing at 30 times an hour, your dead space can be as high as 42 to 45%, which is almost 50% of your lung capacity is now dead space. So all of these have to be taken into account. The higher the breath rate, the respiratory rate, the higher the dead volume, which needs to make sure that you have to compensate for that. Next slide, please. So this is a cartoon which tells you physiological derangement at multiple levels. You can see at the airway level here, he's obstructing. If his upper airways are not open, nothing is going down into his lung in the first place. So effectively, by giving an EPAP of 5, we have ensured that the airways are not even going to open up. Down below, as we said, he's got COPD. Many of his alveoli are destroyed. Because of that, he has significant autopeep. In this cartoon, you see there's almost 15 of autopeep. In order to neutralize 15 of autopeep, you need to have a peep of anything over 10 plus to be able to get that off. On top of that, these alveoli are filled up with fluid because he's got pulmonary edema. So you absolutely need to know these physiological derangements to make a good choice of your vent settings. Next slide, please. So in this case, what we did was we quickly moved on to AVAPS, which is assured volume pressure support. What does it mean? Well, if you look at the cartoon which I showed you of the BiPAP, it's everything is fixed. He's getting certain amount, but that's fixed pressure. And we're not sure how much of tidal volume is being created. And we know that tidal volume is very important to wash out the carbon dioxide and give him the necessary volume. So in AVAPS mode, we are not targeting a pressure, we are targeting a volume. So you set a volume and say, no matter what, this patient of mine has to get 450 ml because that's what we calculated based on his height and his gender, which is the two important aspects of calculating tidal volume, as 450. Then we knew that this patient has underlying sleep apnea. We also has autopeeping. We need to make the EPAP at least 10 centimeter water to overcome those barriers. And once we do that, then IPAP, which is the inspiratory pressure, is set between 16 and 24 to allow the movement of IPAP as breath by breath goes in to accommodate a tidal volume of 450, which basically means, as you look at this cartoon on the top, you'll see how the tidal volume keeps on fluctuating and increasing, or the pressure keeps on increasing, the IPAP, to accommodate a constant tidal volume. So here, instead of BiPAP, which is basically focused on just pressure, we have moved in to assure that this patient gets a certain tidal volume and you're targeting tidal volume. And once you did that and he's getting adequate tidal volume, his minute ventilation is better, his dead space is taken care of, you can see within hours, this patient's pH improved to 7.42, carbon dioxide reduced from 70 plus to 54, and Vicart also started trending downwards. And you saved him an intubation and mechanical ventilation transfer to ICU. Now, this is the screenshot I've given of our Bella Vista an IV device. I have no conflict of interest for devices. The only reason I'm mentioning that is WVU is moving away from the general Trilogy 101 to Bella Vista, which is the screenshot I'm showing you. So it is possible that most of our allied hospitals in the system would also be moving to the system. And the reason is we have to move because Trilogy 101, which most of us were used to, has been found by FDA to be faulty in many parameters, and they're fading that out. They've told the company that we don't want Trilogy. So most of us have been raised on Trilogy. Most of us know Trilogy like the back of our hand, but is no longer going to be in market. Okay, so our ability to understand these devices is critical for our patients because they depend on our knowledge to be able to transfer and then make an appropriate decision based on that. I've made a blue line below that. I've put another device just to be fair on both ends. This is called the IVAPS. Instead of AVAPS, it is the IVAPS, and this is a different company called ResMed. And the idea behind this machine is that, listen, there is a lot of dead space in our airways, and we should not be targeting minute ventilation because minute ventilation is respiratory rate multiplied by tidal volume. However, alveolar ventilation is tidal volume minus the dead space. So we need to account for the dead space. So this doesn't even target minute ventilation. This targets alveolar ventilation. So it takes dead space into account. Okay. We don't have this device, but just for the sake of completion and giving you a balanced view, I wanted to make sure I mentioned that. Next slide, please. So you now suddenly realized that in this entire conundrum, a patient who's admitted with decompensated CHF, actually there is no fixed device. Depending on how you got this patient, how deep he was into his congestive heart failure, how many other comorbid conditions is, your device selection and settings can change. For example, if the same patient I alluded to you came with pure decompensated congestive heart failure with no respiratory failure, CPAP would just alone would have been fine. And that is the recommendation of the ATS guidelines. However, if the patient comes into your facility a little bit too late, hey, maybe I can handle it at home. I think I can get better on my own. And in between, his work of breathing goes worse. He starts getting hypercapnic. His muscles start getting tired. CPAP alone will not help. Same patient. And you have to graduate on to BiPAP. Okay. Now, in our case, it was even more complex. This patient not only came too late, but also had additional comorbidities of obesity, hyperventilation, COPD, and then BiPAP wasn't enough for this guy. And we had to escalate it to AVAPs or in other institutions if they have IVAPs to that restriction. So same patient, depending on the trajectory, you need to move and select the proper NIV. Next slide, please. So this is the CMS, Medicare, Medicaid definition of non-invasive. They define it into two worlds. One is called the respiratory assist device, and the other is called the HMV, or home mechanical ventilators. So on the left side, you see the RADs, which are further divided into, do they have backup or they don't have any backup? If you remember, our patient first got into 10/5, the reflux mode, which most people use. That's the BiPAP S with no backup rate and no ability to change tidal volume. And the backup rate would have backup rate if the patient can't breathe on his own, they will breathe in for him. Home mechanical ventilations are much more higher up. They have, while RADs are assisting your breathing, home ventilation is basically defined as absolutely crucial for survival. So that's the differentiation they make in that. And you see how many companies are available. I alluded to you that we used to deal with Trilogy, Philips Trilogy, but since that's going out and not going to be manufactured, WVU has invested in Bella Vesta, which is number 3 on that. It's manufactured by Vyaire and Zoll. And that's the technology. And how these things differ and how the breath is delivered is very much proprietary. How much of it is automated and how much is physician control is also dependent on which manufacturer is producing which NIV device. One thing in this entire definition of CMS, I'd like to point out that you will not see any CPAP, because CPAP is not considered a ventilatory mode by CMS because there is no pressure support. It's a fixed pressure, whether you're inspiring or expiring. And hence, it is no longer considered as a non-invasive ventilation. Next slide, please. All right, let's move on to patient 2. Now, we moved away from congestive heart failure. What about the multiple COPD patients that you see on a day-to-day basis? 65, 4-year-old, severe COPD, frequent exacerbations, on triple therapy, seems to be compliant on those therapies. This is the second time patient is getting admitted for COPD exacerbation and chronic hypercapnic, acute and chronic hypercapnic respiratory failure. BMI, watch out, is 22. not very heavy, not obese. Height is still tall and lanky, 6 feet. Respiratory rate is getting higher at 24 minutes. SATs are 82% room air. Interestingly, patient is on a home BiPAP of 12 by 8 centimeter and also is compliant on a home device. But despite that, gets admitted. Admission ABG show, again, acidosis. PCO2 is elevated to 71%. Patients treated with steroids, beta agonist, ipratropium, and a BiPAP this time of 16/8 is started on the patient with 4 liters of oxygen bled in. Patient does not respond to that and then is initiated on Trilogy. Remember that Trilogy was still available till last month and responded well to the following ABG, and the ABG is now normalized to 7.40. PCO2 has come down to 58. Next slide. So now you're very happy that you saved the patient from getting intubated. The patient did not get to the ICU. You made the right choice. But now it's time to go have the patient discharged home. What would you do? This is a patient who had an acute exacerbation, but is also at a non-invasive ventilation at home. So would you go in for the universal magic number of 10/5? Or would you place her on the 18/8 centimeter because she was at home on 14/8, and now you think she may need more, could be 18/8? Or would you put her on a home ventilator with tidal volume of 450, respiratory rate of 16, EPAP of 10, IPAP of 22, rise time of 600 milliseconds, and a cycling time of 20%? Or would you put him on a home ventilator with tidal volume of 450, respiratory rate of 16, EPAP of 5, IPAP of 22, rise time of 300 milliseconds? Or would you say, I'm not going to put any RADs or HMV since I have no idea what that's happening at all? So since there's a lot of expertise in this group, I would encourage someone from our T to what would they be willing to do that? And there may not be one good answer, but I'll give you my rationale as to what we did.
We did have a response in the chat saying B.
Okay. So yeah, I think that, as I said, that there may not be any right answer. A definitely is the wrong answer because I think that even at home, she was in a higher pressure and 10/5 really doesn't cut it. You could make a case of BiPAP of 18/8, but remember that this patient even failed higher BiPAP settings and had to go on a ventilator AVAP settings in a hospital. So generally, when a patient is getting readmitted within 3 months period of time, is compliant on her BiPAP at home, we think there's a progression of the disease. And you have to keep adjusting for the progression of the disease. That's one other very vital element in non-invasive ventilation, is not static. Just because we gave you a certain non-invasive ventilation setting a year doesn't mean that has to be revised, that this patient may need that. So in our situation, we felt this patient is going to get readmitted again if we don't escalate this patient to a home ventilator setting. The question was, what kind of home ventilator setting should this patient be on? And since the tidal volume we had already determined had to be 450, and it is the same in both, you'll recognize that there are many other settings which can make or break this patient's outcome. And we realized in this patient, in the previous patient, that the patient has sleep apnea, so we had to go up on the EPAP to control that for patient to be holistically treated. We remember in this patient, the BMI is very low at 22. This patient has no evidence of sleep apnea. So this patient will not tolerate that high an EPAP. So we need to keep that EPAP low. Plus, one of the things we have learned over the last few years, and I'll show you some evidence of that, is in specifically hypercapnic respiratory failure because of COPD, it is now noted that instead of chasing a certain pressure support, we need to chase hypercapnia, which means your driving force has to be higher and higher than traditionally that we've been thinking about. So the driving force is nothing but IPAP minus EPAP. So you can see the driving force is much higher in the D, which is 22 minus 5, rather than 22 minus 10. Okay. And that may be much more beneficial in keeping this patient at home than getting readmitted and having more poor outcome. Next slide, please. Okay. So to understand certain nuances, again, this may be getting a little bit too deep into physiology, but I wanted to give you a little flavor of how a breath appears to you like. So this is a single breath. You can see at the base is the EPAP, and then it rises to IPAP. How quickly it rises to IPAP is your rise time. That is essential in making decisions for these patients in non-invasive ventilation. I'll give you an example of this patient who has got severe COPD. He's got very weak diaphragm, is air hungry. This patient cannot wait for too long for that air to get to him. So the rise time has to be real fast. Otherwise, this patient would not get enough breath. He'll start increasing his work of breathing and slowly start circling the drain and not do benefit. So just because we had the right tidal volume, just because we have the right backup rate, doesn't mean that this patient is going to fail. If your other parameters are not set right, this patient more likely is going to get tired because you're not given what the patient wants. So this patient, I would keep the rise time very short. Like in COPD exacerbation, COPD patients for home, 200 milliseconds is what they want. They want it quick, they want it fast, and they want all of it. Then on the other end, you will see on the thing, you say something called cycle at the end of the breath. That cycle is, when do I terminate the breath? And this is a very important determination, especially in COPD patients. We talked about COPD patients, how they take a breath in, but they can't exhale out. Everything gets trapped in. These patients fundamentally require much longer expiratory time than inspiratory time to empty out their lungs. In order to do that, cycling time becomes fundamentally critical. What you want to do is in COPD patient is cut off their cycle as quickly as possible. And that depends on where you set that margin at. And typically in COPD, 50%. When your flow rate goes down to just 50%, you cut off that so they can get all the time to expire and deflate their lungs and not have that auto PEEP build up. Okay, and that will be another reason for their failure if you don't do that. On the bottom side, I've given you another cartoon as to how we can make the rise time very high in these patients by moving it towards the left, and then cut off their breath, cycling much earlier than needed to be in order to give them the best possible tools for success at home. Next slide, please. So again, this is telling again in COPD patients, you want a very high rise time. You want them now, you want them there. Same with neuromuscular disease patients. These people are air hungry. They can't breathe. They want it now. In COPD patients, you want an expiratory time to be prolonged. And in that case, you want to cut off that cycle at 60%, as you can see over there. However, in neuromuscular disease, where their muscles are weak, you want to keep that along because you want the alveoli to be recruited. Okay, they don't have a problem of retaining air inside the lungs. Next slide, please. So going back again, other than the tidal volume, minute ventilation, these parameters of when to trigger, what is the cycle sensitivity, what is the rise time, what is the T time, become critical for the success at home and not get readmitted again and again. Next time, next slide. So we already talked about COPD. I'm going to skip this slide. These are basically the same settings I had discussed. And this is that big trial which I was talking, which was published called the HOT HMV trial, which said in COPD patients, don't focus on the pressure. Don't focus on the IPAP and EPAP. Focus on the driving pressures. Focus on hypercapnia. The bigger your driving pressure is, and in this study, they use driving pressure of 20 centimeter water pressure. That can sometimes be very high, difficult for patients to tolerate. So the ATS guidelines have come in. Yes, it should be high, but should be adjusted to patient comfort. And you can see there's a mortality benefit if you make the driving pressures high. So this is a very unique condition in COPD patients having a high driving pressure requirement. Next slide, please. Again, as I said, the biggest difference between AVAPS, Trilogy, and IVAPS, which is a ResMed, is that they target minute ventilation or target ventilation, while IVAPS targets alveolar ventilation, which means they take dead space into account. Next slide, please. Next slide. Back. So moving on to neuromuscular disease, patients with ALS, we have a huge clinic, patients who may have, diaphragmatic paralysis, severe thoracic abnormalities. CMS guideline says if your FVC is less than 50%, your MIP score less than -60, or you start retaining carbon dioxide, that's the time you need to consider non-invasive ventilation or home ventilation at home. Next slide, please. In this patient, it is critical to consider home ventilation, because if you look at this pulse oximetry, this was done at home on a patient, and you can see that the patient's oxygen remains fine. And then all of a sudden it drops, like is going down into a crevice. And then it picks up and then goes down. What is happening here? What is happening is this patient is going into REM sleep. During REM sleep, your muscles get paralyzed, and these patients don't know what to do, and suddenly their respiratory status collapses. So you need to be able to factor this, and that's why you need to have a backup rate. You need to have a fixed tidal volume that whenever these episodes happen in the middle of the night, the machine can jump up and fix these sudden episodes. Next slide. And again, as opposed to COPD, in patients with neuromuscular disease, the problem is you need to open up these alveoli and keep these alveoli open as long as possible to give them as much oxygen boost as possible. So in this case, you want the rise time to be slow, and you want your cycling time to be as delayed as possible so that they can get as much oxygen and recruitment of alveoli as possible. Next slide, please. Again, as I said here, in the neuromuscular disease, you may want to target dead space more effectively. You may want to target alveolar ventilation rather than be trusting on just the minute ventilation and the tidal volume. Next slide, please. So here's a patient of mine who would be in a very advanced case, 63-year-old with tetralogy of Fallot, status quo repair, has significant pulmonary hypertension, has interstitial lung disease. You can see here a CAT scan, this significant interstitial disease, more on left than right. And you can see that there's also a significant hemidiaphragmatic paralysis on the left side, which is reducing your lung volume on the left significantly down. So a TLC 71%, a diffusion capacity is down to 32%, and a ratio is 73%. How do you ventilate such an advanced case of both an interstitial lung disease as well as neuromuscular disease with your diaphragm being paralyzed? Next slide, please. So in this patient, these were the settings which the patient came to me with. They had minimum EPAP of 11, EPAP of 16, and on surface, they look fine, except when we did an ABG, she was going into CO2 narcosis, complaining of severe headaches, and sometimes her family said she would just pass out. She was also complaining of aerophagia. So one thing as soon as we looked at the clinical picture, we realized this patient BMI is not more than 20. She's basically skin and bones. Why is the EPAP at 11 centimeter? That is just blowing too much pressure into the lungs, where you don't need that much pressure because there's no evidence of obstructive sleep apnea in this patient. What was that doing was it was robbing her of the driving pressure, which she needed. So next slide, please. So the changes we made was we reduced the EPAP to 8, and I would probably agree with any of the audience which said even EPAP of 8 would be more. You could have come down to 5, and I would probably say I agree with you. But we were at that time, the first time I've seen this patient, I was trying to make sure that I don't make any dramatic changes. And I increased the max EPAP pressure support from 8 to 14. It used to be 16. I increased the tidal volume to 500 instead of 425 because of the dead space issue. And I increased the backup rate from 6 originally to 14 so that she can get the appropriate minute ventilation and alveolar ventilation. And I changed the rise time, as you see, was originally 400, and I changed it to 200 because these people are air hungry. They need air now. I need to have my breath now. And then within a week's time, you can see the pH normalized, PCO2 is 74, and patient's headache had gone away, and patient was feeling much better. I'm still not happy with the CO2 of 74, and we're still working on that, but you can see how dramatically you can make these situations different by changing these parameters. Next slide, please. So again, few points that COPD is very different than restrictive lung disease, and you need to make sure that the I-rise time in the COPD is much shorter, and in restrictive lung disease, especially with diaphragmatic failure, it has to be a little bit higher. But in our case, it was very complex because the patient had both interstitial lung disease as well as a neuromuscular disease. The air hunger was much more, and I had to shift over to a shorter rise time. Next slide, please. So sometimes it is very helpful to get these downloads from these machines, and I don't expect a primary care physician to be able to get all of these numbers and know how to make those changes, but it is a good idea for people dealing with non-invasive ventilation to be well versed with these downloads and how they interact. Next slide, please. So what have we learned as primary care physicians and as people taking care of these respiratory wrecks out there, not in the hospital, but also in the community? That this default 10/5 needs to go away. It is not based on fact. And I think, in fact, in my opinion, it is very detrimental. And it is important for us to understand our knowledge has moved way beyond that universal settings. Trilogy, BiPAP, AVAPs, IVAPs are for treating respiratory failure. They are not sleep apnea modes. So we need to also be able to distinguish. Your patient comes to see you and is on AVAPs, that is not a CPAP treatment just because they're using a mask. DME companies are great to replace supplies, troubleshoot leaks, obtain compliance reports, but they are not good for interpreting ABGs, optimizing AVAP's target, adjusting I time, evaluating the persistent hypercapnia, and then adjusting to the natural progression of the disease. That has to be done. So even you see a patient, don't just say, "Oh, using a mask, DME got it." Who is your pulmonologist or sleep physician who is taking care? When was the last time they saw these settings that it was? And if you see more than 6 months, that is a time to raise some alarm bells as to why you're not seeing them. Next slide, please. So I'll end up with saying is that the take-home message for every one of us is when you're dealing with these advanced devices, and they're just going to get more and more in the community. That is the trajectory we are seeing universally. You got to ask some important questions. Are you using your ventilator every night? First of all, is it a ventilator or is it a CPAP machine? Do you wake up with headaches? It could be a sign of carbon dioxide being retained in your body. So before they get comatose, you need to pick that up. Are you feeling more and more sleepy, tired, and fatigued than you were 6 months ago? And then if you find out this patient a ventilator, very important, quick question, even if you can't troubleshoot the vent is the ventilator chasing you or are you chasing the ventilator? Very important question. It means, are you getting too much air that you're running away from it? That means we need to back off on that. Or you are air hungry. Every time the machine gives you, you feel dissatisfied. You're not getting what you're looking for. So this question has become very fundamental. Are you chasing the vent or is the vent chasing you? And then when was the last time you saw the settings with reviewed with pulmonologist, sleep physician, having a patient say, no, my DME company got said they are setting up these pressure settings and they come and see me is no longer valid. It should not be the standard of care. With that, I thank you for your attention and happy to take any questions from the crowd.
Yeah, hello. I have a question for you, a couple questions. This is Tim.
Hey, Tim.
So